Thanks. I'm happy to be here this afternoon to talk about management approaches to slip capital femoral epiphysis. I have no disclosures for this presentation. My objectives are to discuss the conventional management approaches for slip capital femoral epiphysis, as well as some of the current controversies. So as we know, slip capital femoral epiphysis, or SCFE, is defined as displacement of the femoral neck metaphysis relative to the femoral head epiphysis through the level of the growth plate. The displacement is typically anterolateral translation as well as external rotation. We do not know what causes slip capital femoral epiphysis, and it should be distinguished from femoral neck fractures, particularly Delbay 1, because it behaves differently. SCFE is usually characterized by antecedent epiphyseal lysis, slow displacement, and has an intact periosteum and or perichondrium. It's important to recognize SCFE because it can lead to long-term sequelae, including loss of hip motion, premature osteoarthritis, and physical disability. SCFE typically presents in older children, adolescents, during their peak growth velocity between the ages of 10 to 15. The prototypical patient is the obese adolescent male. Atypical presentation of SCFE includes patients who have endocrine or renal disorders, as well as those who've had previous radiation therapy. SCFE can be classified as either based on their chronicity, severity, and stability. From a clinical standpoint, stability is perhaps most telling for prognosis and for guiding treatment. It is defined conventionally based on the Loader classification as being stable or unstable based on the patient's ability to bear weight, either with or without crutches. And essentially, this classification is a surrogate to determine whether the epiphysis is stable or unstable on the metaphysis. Physical exam, patients can present with a painful antalgic gait or Trendelenburg lurch. They can present with external foot progression angle. They typically have limited flexion, internal rotation, and abduction of the hip. And with hip internal rotation, they can have or complain about hip pain, groin, thigh, or knee pain. They typically also exhibit the characteristic obligate external rotation with hip flexion. And the video on the bottom right demonstrates why obligate external rotation occurs with SCFE, and that is that with flexion of the hip, the metaphyseal bump at the femoral head-neck junction engages the acetabular rim, and as the metaphyseal bump rides along the rim posteriorly, the hip is obligated to go into flexion, as seen there. Standard imaging for SCFE includes bilateral AP and infralogic lateral of the hip. Of note, for unstable SCFEs, cross-table lateral is preferred so as to not cause further iatrogenic displacement of an unstable slip. Qualitatively, Klein's line, which is the superior aspect of the femoral neck, if abnormal, does not intersect the epiphysis. There may be widening or irregularity of the physis, which is a result of epiphyseal lysis. There may be metaphyseal blanching as a result of superimposition of the epiphysis and metaphysis. And quantitatively, we can measure the Southwick angle, which is the lateral epiphyseal shaft slip angle difference from side to side, to determine how severe the slip is. For ambiguous cases, such as those early slips without obvious radiographic findings, we can obtain an MRI, and they can sometimes demonstrate physeal edema and/or a small joint effusion. Once a SCFE diagnosis is made, the child should be immediately made non-weight-bearing, restricted to either using crutches or wheelchair, and then be referred to an orthopedic surgeon at a hospital for timely treatment. The main goals are to prevent further slipping, minimize avascular necrosis of the femoral head, avoid subsequent femoral acetabular impingement from the post-SCFE deformity, and prevent early onset osteoarthritis. For patients who present atypically, such as those who are younger than 10 or older than 16, below the 50th percentile for height, weight, or BMI, and those presenting with a valgus slip, we should consider getting laboratory screening to rule out endocrine and metabolic disorders. For stable slip, the consensus standard treatment is in situ fixation using one screw. These are typically 6.5 or 7.3 millimeters cannulated screws, and if we use stainless steel or fully threaded, this can facilitate later removal in the future if indicated. The screws should be positioned centered in the epiphysis, perpendicular to the physis, at least 4 to 5 threads across the physis on one view, and no closer than approximately 5 millimeters from the tip to subchondral bone on all views. This can be assessed using either incremental fluoroscopic images or using the approach withdrawal method with a live fluoro. Concomitant osteochondroplasty has been described as particularly for more severe slips, but this is controversial. For unstable slips, treatment is a bit more controversial. Traditional treatment has been incidental or inadvertent reduction of the acute component of the slip, just from standard patient positioning, followed by percutaneous screws using 2 screws. Capsular decompression has been described to decrease the pressure on the lateral epiphyseal ascending vessels that feed the femoral head to decrease the risk of AVN, as well as epiphyseal perfusion monitoring using the ICP monitor can be considered, but again is somewhat controversial. Another option is to perform either intentional closed reduction using the lead better maneuver with abduction, flexion, internal rotation, followed by adduction and extension of the hip to place the epiphysis back onto the metaphysis without pinching the retinacular sleeve. Alternatively, open reduction has been described, for example, using the Parsh technique with a small open incision, allowing the surgeon to insert a digit to softly reduce the epiphysis back onto the metaphysis. And then more powerful techniques have been described, and these are more invasive. These include the in situ screw fixation, followed by either a primary or delayed Imhauser osteotomy, which is a flexion, abduction, internal rotation osteotomy to correct the scaphy deformity, or the modified Dunn procedure, which is a subcapital reduction of the epiphysis back onto the metaphysis in acute fashion via surgical hip dislocation approach. Both of these are relatively controversial. And it's controversial because of the risk of causing iatrogenic AVN of the femoral head. In the literature, there are studies that have described low rates of AVN using the modified Dunn procedure, but there are also studies that show up to 20 to 30% AVN rate. And therefore, at this time, modified Dunn procedures should really only be limited to the acute, severe, and unstable slips and performed in a timely fashion, ideally less than 24 hours by surgeons who are experienced with this technique. A recent poll of North American pediatric orthopedic surgeons demonstrated an equal distribution of using one of the 3 aforementioned methods for treating unstable slips. So the jury's still out as far as what is the optimal treatment. Bilateral slips can also occur in up to 30 to 50%, either simultaneously or for the majority of patients within the first 18 months of the first slip. Treatment for this is typically prophylactic in situ screw fixation of the contralateral normal hip, but this is controversial. Prophylactic pinning should perhaps be considered for younger patients, boys less than 12, girls less than 10. For atypical presentations of SCFE. The modified Oxford Bone Age score has been devised to guide treatment. This is based on scoring of the closure of the growth centers around the hip, A score of less than 19 can be associated with up to 96% of risk of contralateral slip, versus a score of 20 or greater has a risk of less than 5%. This study also showed that the triradiate score in and of itself, if it's 1, is associated with a slip risk of 89%. So contralateral pinning, or screw fixation rather, is not in and of itself a benign procedure. A multi-center study has demonstrated a 2% risk of peri-implant fracture, as well as a 2% risk of AVN. So this should be considered and discussed with families before making this decision to fix the contralateral side. Postoperatively, patients are typically restricted in their weight bearing for up to 6 weeks using crutches. Weight bearing is then allowed without crutches for stable slips after 6 weeks. And in certain practices, including my own, with crutches, weight bearing is tolerated for 6 weeks for unstable slips. Activity as tolerated for stable slips at 12 weeks, and then for unstable slips, they can wean off crutches. Finally, activities as tolerated for unstable slips after 6 months. Because there is a risk of contralateral slip within 18 months, follow-up of the patient every 3 to 6 months should be done until skull maturity, or at least up to 18 months to 2 years. Complications after SCFE include post-operative slip progression, and this can perhaps be prevented by making sure that at least 4 to 5 threads of the screw are across the physis, contralateral slip, femoral head avascular necrosis, chondrolysis, which can be prevented by avoiding screw penetration. And then in the long run, post-SCFE femoral acetabular impingement with or without labral tear and chondral degeneration can occur. And there are various treatment options for that, which is beyond the scope of this talk. So in conclusion, SCFE is the most common hip disorder in adolescents. The chronicity, severity, stability classifications can help guide our treatment. Current standard of care for stable SCFE is in situ screw fixation, whereas the management of unstable SCFE is more controversial and evolving. We should evaluate the presence and the risk of bilateral slips. And there are still many controversies that exist, and further studies are needed to optimize patient care and long-term outcomes after SCFE. Thank you.